Good morning, everyone, and welcome to the Lurie Roundtable discussion on infantile spasms. I am Julie Kalkbrenner, one of the physician liaisons for the West and Northwest suburbs. We are delighted to share a day's worth of epilepsy talks with you. Some of the discussions today will cover epilepsy an overview, which we just had earlier this morning, infantile spasms, the EEGs, keto diet, and epilepsy surgery. All of these sessions today will be recorded and will be available on the Physician Services webpage. The infantile spasm program today will cover about 25 minutes of content from Dr. McDonough, and then we will allow some time for question and answers. The questions can be typed into the chat box or the question box on your right side of your screen. Dr. McDonough is an attending neurologist at Lurie who specializes in neurology and fetal health, and she hosts an infantile spasm clinic and also works with the epilepsy program. She sees patients at Lurie Children's as well as by telemedicine. I would like to introduce you to Dr. Tiffany McDonough.
Hi, everyone. Thanks for joining today. I'm going to chat a bit about infantile spasms and give you an overview as well as how to reach us and sort of how we work up patients. So I want to make sure you can see my slides. I have no disclosures today. Here we go. So today I'm going to review the clinical features and causes of infantile spasms, or the other term that we often use for it is West syndrome. We're going to review the rationale for the importance of early diagnosis and treatment, how other types of abnormal movements that are common in infancy can be confused with infantile spasms, and also when to refer to us, and identify for you some resources for connecting pediatricians and the general community with our epilepsy team. So infantile spasms are a type of brief repetitive seizure, and these spasms tend to cluster. So the individual seizures are quite short, but the clusters themselves can last up to hours at times. They typically involve the muscles of the neck, trunk, and extremities, and they can be flexor, extensor, or mixed. It's a type of rare infantile onset epilepsy, and as you've heard, epilepsy just means that you have recurrent, unprovoked seizures and an ongoing risk for seizures, which we identify either by an underlying diagnosis or by EEG findings. 60% of patients with infantile spasms go on to develop other types of seizures or epilepsy. And they typically present between age 3 to 9 months of age, with 90% of cases occurring in the first year of life. And the onset of these can range from the first weeks of life in rare cases out to 4 to 5 years. So in this bell curve, but most of the time they present in the first year. So the early recognition of spasms and the prompt treatment are mandatory and ultimately may improve developmental and cognitive outcomes in some patients, which is why this is so important and considered a neurologic emergency. So the epidemiology of infantile spasms, we see anywhere from 2 to 3 per 10,000 cases in live births worldwide, which equates to about 2,500 new cases per year in the US, with a slight male predominance. And here at Lurie, we probably see up to 2 or 3 per month. So we do see a very, despite this being a rare condition, we see it very frequently at Lurie, which is why our program has been growing. The response to treatment and the long-term outcome really depends on the underlying cause of spasms, which is why that's such an important part of the workup. So just to review, West syndrome is a triad of infantile spasms, an abnormal EEG pattern called hypsarrhythmia, which you can see on the right side of your screen, which is a high amplitude, disorganized, very chaotic EEG pattern. And then also in West syndrome, we frequently see developmental regression. So West syndrome is sort of used interchangeably with infantile spasms. And the term comes from the original doctor, the British physician who described infantile spasms, Dr. William West, who actually described this condition in his son and published his case in the Lancet. It's very sad. Started having head nods at 4 months. The baby had developmental regression and then later on developed convulsions and Lennox-Gastaut syndrome, which is a complex refractory childhood epilepsy. So we kind of think about infantile spasms in a few different categories, and the most frequent or common cause of infantile spasms is this category called symptomatic, meaning that there's an underlying cause leading to the onset of infantile spasms. And we can often identify this either at spasm onset or rapidly. So about 60 to 70% of patients ultimately receive a diagnosis in this group. And we think about this in prenatal, perinatal, and postnatal causes. So prenatal causes involve central nervous system malformations, tuberous sclerosis complex, congenital infections, other identified genetic conditions, trisomy 21 being a common cause, or other inborn errors of metabolism. And perinatal causes are sort of intrapartum events such as hypoxic ischemic encephalopathy, neonatal glycemia, or sequelae of prematurity with neurological injury. And postnatal causes in the early infantile period, so trauma and also central nervous system infections. Then there's this other category called cryptogenic, which is where we can't quite identify an underlying cause, but we presume that there is one. And there's up to 30% of cases where we presume something is genetic or symptomatic, but we just can't put our finger on it despite an extensive workup. So these patients have no other types of seizures. They sometimes have a normal examination, and they have an EEG with that classical finding. And there may or may not be some developmental delay that emerges or some other features, but we haven't been able in those cases to necessarily identify a cause. Often these are genetic causes. And then there's a very small proportion of patients that actually have the best outcome that we consider something called idiopathic, meaning that their development trajectory doesn't change. They have normal development before the onset of spasms, and then they recover quickly with normal examination and imaging. Those patients have the highest chance of the best outcome with our initial treatment. Many babies, of course, as you all know, make a lot of funny movements, and so spasms can be kind of tricky to identify, and that's why the EEG is so important, but they can often be confused with colic, reflux, an exaggerated startle reflex. And the keys to differentiation are that spasms cluster. The individual seizures, again, last about a second, but they can recur repetitively every 5 to 15 seconds, on average up to 20 to 30 minutes. But again, as I mentioned, some may last up to an hour or more. They occur frequently with a sleep-wake transition. So commonly parents will mention, oh, my baby was waking up and they did this funny movement repetitively as they were becoming more awake, or after feeds, they're a little drowsy and that's when we see it. But it can occur during the daytime as well, typically not in the middle of the night unless there's some sort of arousal or awakening. You can see body crunches with it, which is maybe a little less typical for your reflux and startle reflex, head bobs, or even just a subtle eye roll or facial expression change. I just want to take a moment to show you a couple of good examples on video. And these videos are provided by the Infantile Spasms Consortium out of the UK. This little guy, pretty normal behavior in between, but he does that little like shudder stiffening and his facial expression changes. There you go, right there. And it's clustering. But it's not postictal. It's not even really irritable in between. That's one pretty good example. They can be pretty subtle, but I also want to show you this other type, which is actually more of the loss of tone. Oops.
This is the world's first reusable cotton swab.
The problem with YouTube. Here we go. This little guy is hanging out. Again, normal behavior. And there he goes. And that's a spasm with an extension of his arms. That's kind of the key there, differentiating it from an atonic seizure of some kind. And I think if he weren't sitting in this chair, he might fall backward. He has that little head nod with it as well.
Okay. Hey, boy. That's my boy.
And then just another potentially more subtle example. This baby has slightly less, I would say he has some limited movement repertoire. So maybe some not normal baby movements in between, sort of more limited in his movements. And you'll see over time that right arm extension becomes a little bit more prominent, and he'll start to have some facial expression changes along with that. His eyes get a little wider. right there is a good example. These can be tricky to identify, and so the EEG becomes an important component of that to differentiate from behaviors. So important EEG is really how we evaluate these. The important thing is to characterize what's happening in those brain waves in between the seizures, so the interictal background, as well as the spells themselves, the ictal pattern. In addition, a thorough neurological examination and an extensive medical and developmental history with a focus on birth history, an MRI of the brain, and a metabolic workup. So we often do a screening blood work for metabolic conditions that may not have been picked up on the newborn screen. A lumbar puncture looking at neurotransmitters and other biochemical markers. And then a key component now is our genetic workup. So we have an availability to do an in vitae behind the seizure panel for all of our patients, which tests about 150 known epilepsy genes, as well as a microarray. And then ophthalmology and dermatology to screen for neurocutaneous syndromes. So our treatments for infantile spasms, we have a number of options, but the first line treatment in the US and most countries is steroids, in particular ACTH. And the goal is cessation of spasms and resolution of that hypsarrhythmia EEG pattern. The first round of treatment with ACTH leads to resolution of the spasms in about 40 to 80% of patients. Again, this is very dependent on the underlying cause of the spasms. And on average, taken all together, 1 in 3 will relapse or not respond. The mechanism of this is not well identified. And there's some variable protocols for steroid use, not only with the ACTH intramuscular therapy, but there are some oral prednisolone or other steroid formulations that we use depending on the clinical context of the patient. So many patients we will use prednisolone, and although there's some mixed data, we roughly consider them equivalent. The first line, however, in tuberous sclerosis complex is vigabatrin, which is a GABA agent. The typical length of treatment for that drug is up to 6 to 9 months, depending, again, on how the patient responds. And this is because there's a black box warning for vigabatrin related to vision, which was seen in adults on the medication, but it is a black box warning. So we try to use that medication for limited duration. We also use ketogenic diet. Our Lurie Children's ketogenic diet program is very large, one of the largest in the country. And so we do use that essentially as a second or third line agent in many cases. There's also standard anti-epileptic treatments that we use when patients are more refractory. And then always we're considering whether or not patients are an epilepsy surgery candidate, particularly for patients who have an identified brain lesion. We often will consider epilepsy surgery early on in their course. So, we work very closely with pediatricians because there's a lot of side effects of these treatments, and pediatricians often get a lot of phone calls about these. And also we ask that patients do very close monitoring, at least during their initial steroid treatment. So the things we're watching out for, as you might imagine with steroid treatment, are hypertension. So we do frequent blood pressure monitoring during treatment, immune suppression and infection. And the question always comes up of how do we address vaccinations? And the guidelines are there's a delay in live vaccinations for 4 weeks and all vaccinations during the duration of treatment. So that ends up being at least a 4 to 6 week delay in some forms of vaccinations, depending on the age of the patient. We monitor for electrolyte disturbances, as you might imagine, because steroids can certainly do that, so monitoring weekly. Reflux can get worse, gastric irritation on steroids, so we do prescribe GI prophylaxis during treatment, which we can stop at the end of the steroid course. We ask that there's hemocult monitoring weekly while on treatment. And some of the behavioral changes are some of the most distressing to parents, as you might imagine. So a lot of irritability, excessive hunger, sleep changes. This is really during the duration of treatment and resolves after the steroids come off. And again, we use steroids for about 4 weeks time, 4 to 6 weeks time, depending on the formulation. So we have to counsel parents, you know what, this is gonna get better. This is sort of roid rage that your baby's going through, so don't worry too much about it. It's going to get better. Weight gain, fluid retention, and also Cushingoid features can develop. And again, the short duration of treatment is really to minimize the side effects and the risks of all of these medications. And while on vigabatrin, there's a similar recurrence rate of spasms to the hormonal therapies. So we do use them in combination. The most common side effect is fatigue or sedation. And some rare but important side effects are this black box warning for irreversible peripheral vision loss, risk that's very low in infants. We monitor with serial ophtho exams. So every 6 months, we'll have these patients if they are on a longer course of vigabatrin, which is something we do use in tuberous sclerosis for a more extended period of time. And also a very, very rare syndrome of toxicity that's important to know about. So some patients will develop a movement disorder where they have choreiform movements or myoclonus or jerks and encephalopathy with a lot of sedation and decreased activity. And then when we get an MRI as part of the workup for what's going on with the toxicity, we can see some involvement of the basal ganglia. So we stop the medication in that instance and the symptoms slowly resolve. But again, that's an incredibly rare condition, less than 10%, and probably even less in my clinical experience, but very important to know about. So we want to welcome a very active collaboration in monitoring these patients on treatment with their pediatrician. So during steroid therapy, we have a clear protocol of twice weekly visits in the pediatrician's office for blood pressure and weekly serum electrolytes and glucose monitoring, as well as following any gastric discomfort or changes in bowel function. And guidance during the immunizations being very important because there's a lot of anxiety surrounding vaccinations, not just during treatment, but also, the involvement of seizures and triggering of seizures with vaccinations. And so we welcome an open collaboration and counseling with the families together. Your role, of course, is to provide reassurance during these things and also to have an open line of communication with us. And if you have access to our EPIC system, we have a clinical care guideline available, which goes through our whole protocol and sort of how we think about it, the dosing, and also some of the other parameters of our monitoring program while on particularly the initial steroid treatment. So a quick referral is really key if you are concerned for spasms. Again, babies do a lot of funny movements, but if you have a low index of suspicion, to refer to us. Don't hesitate to contact us by Rapid Connect, which you'll reach the epilepsy attending on call in that instance, or you can call the epilepsy center at the phone number there. We will help facilitate rapid evaluation for new diagnoses or second opinions, usually through an admission because we need extended EEG monitoring, although we can utilize our routine EEG lab, which you'll hear about from Dr. Stack later on this morning. But often we'll admit to neurology via the ER or through a direct admission if that's appropriate, so that we can monitor on EEG, identify the spasms and the EEG background, and really coordinate the care and the initial treatment because there's, as you might imagine, there's a lot of coordination with insurance to obtain these medications, which are expensive and rationed, if you will. So we really want to kind of be holistic about getting treatment started. We really want to welcome a lot of collaboration and any questions about any patients that you might be concerned about with spasms. This is our infantile spasms team. So I work closely with 2 nurses in our epilepsy center, as well as nurse practitioner Amy Tennant, and our ketogenic diet team. So we're really collaborative and have a clinic that we're building up in our frequency at least twice a month, where we're all working together to see patients, because there's a very close follow-up, at least within the first 6 months of treatment, with serial EEGs, testing, changing medications, and a lot of counseling and reassurance about prognosis. This is our website here. And there's a lot of resources, which if you have these slides or if you've got the video just to provide to you in terms of providing these to families, the Infantile Spasms Action Network and the TS Alliance. Also the Epilepsy Foundation and Cure Epilepsy, both are Chicago-based regional they're Chicago branches of national organizations, which can be really informative for families in terms of networking programs, connecting families together. So these are really great resources for not only families, but providers as well. Our Infantile Spasms Awareness Week is coming up here shortly, but the key here is to detect these abnormal movements. You can have families take videos. You can take videos and send them to us. We will rapidly obtain a diagnosis and initiate quick treatment. So that's all I have. We hopefully will have some time here for questions.
Thank you, Dr. McDonough. That was excellent information. Can you also, I know we had talked a little bit before, we have a telemedicine, you have a telemedicine component to your clinic. Can you talk a little bit about that?
Yes, so we actually, we do have in-person clinics at least once a month for infantile spasms, but both Amy Tennant and myself have a telemedicine clinic specific for infantile spasms. Tends to be on Thursdays. Thursdays is Spasms Day for us. So that's another way that we can facilitate rapid coordination of care for patients, especially since so many families find it challenging to get into downtown Chicago, or a lot of special needs families have equipment or challenges with getting to the clinics. And so this is a really nice way to have very close follow-up with families, but also see children in their home environment where we can get a much better sense of their overall development and interactions. I find that very helpful in my assessments. I'm doing almost at least half of my clinics are now telemedicine. And I think it's a great way for families to connect with us.
Excellent, thank you. If there are any questions from any of the participants, please feel free to enter them in the chat box or in the question box on the side. One other question I did have is when referring a baby, do you want the pediatrician to do any of the workup, any of the lab workup? Is there anything you can recommend right there?
I think with referral, that's not necessary. If you contact us, we can, most of the time we do need to end up admitting the patient to do a prolonged EEG and to try to obtain an MRI quickly. So referring in to us for either via the emergency room, or we can sometimes facilitate a direct admission depending on the clinical status of the patient. You can always order a routine EEG. So even though a routine EEG is about half an hour, 45 minutes long, there's some important information that can be obtained from that, even if we don't capture the actual spasms on the routine EEG. So we can see the background patterns and see if there's anything alarming, and then admit the patient from the EEG lab. We do sort of the gold standard of trying to diagnose spasms is a video EEG. And so that's the important component. We don't have a video on a routine EEG, at least in our lab at the moment. And so capturing these spells on video and concurrently assessing the patterns of the EEG during the abnormal movements of concern is really crucial to making the diagnosis. But what I can say, not infrequently, probably most of the time, is that babies not only have, the spasms that we're seeing, but also other movements. And so it's important for families, for parents, and also for pediatricians to be able to know what's spasm and what's not, because certainly families' anxiety about the movements increases with this diagnosis. And so it's really important to empower them to know what's of concern, what they should contact us for, and what's just kind of normal baby stuff.
Excellent. Okay, thank you. As you were just talking about EEGs, we will have a session today at noon with Dr. Stack and a couple of the other techs within our EEG diagnostic area. They'll be going through the EEG, when to order, how to order, and explaining results to families. And then today at 3 o'clock, we will have a discussion by one of our dietitians on the ketogenic diet, which we're all eagerly awaiting to hear. And then at 5 p.m. today, we'll be closing it out with Dr. Wu, who has some epilepsy surgical procedures that she is using in the epilepsy center as well. So I think that might wrap it up for our questions for today. Again, Dr. McDonough can be reached through calling the epilepsy center. And then also we have Lurie MD if you need to get in touch with a neurologist rather quickly, looking for a physician-to-physician consult. So thank you everyone for joining us today, and we hope to see you at one of our other programs this afternoon. Thank
Okay.
you.
Take care.